Welcome wherever you are in the world, whether it's morning or evening or afternoon. I'm Annie McCluskey. I'm an occupational therapist and a member of the StrokeEd collaboration. I'd like to start by acknowledging the traditional custodians of the lands on which all of us as presenters are working and living, and pay our respects to elders past and present. Simone and Zhang are based in Sydney on the eastern part of Australia. I'm based on the central coast, north of Sydney, and Claire is based in Dubbo in central western New South Wales. This lecture series, this is the fourth of 5 lectures, is intended to make you think and hopefully to change your practice or what you teach if you're an educator. The focus on de-implementation for the 5 lectures is about changing something that you're currently doing in treatment, therapy, or in a health service, and stopping that treatment. The definitions refer to abandoning a treatment, which sounds a bit serious, but it's stopping doing something that you may have been doing for many years, for most of your career, and because there's a more effective treatment, or there's a treatment that, or there's perhaps evidence that shows no effect of that treatment. In the case today, we're looking at one therapy called task-specific training that's been shown in 2 systematic reviews to be a better treatment for improving arm function and lower limb function after stroke. And you'll hear about that from Simone and Zhang. If the information you're hearing today is new to you, is a surprise and makes you uncomfortable, or stirs up your emotions, then you're probably not alone. Behavior change and change in your practice is difficult. And if it's something that you have spent a lot of your life working to develop skills in and attending lots of workshops, and you know that you're going to have to learn something new, that's a big ask. But really what we're asking clinicians and managers and educators to do is to think about how to stay in line with the evidence and to make sure what you teach and what you practice and offer to people is evidence-based. Simone, who's going to start the presentation, is an associate professor at the School of Allied Health at the Australian Catholic University in Sydney and a member of the StrokeEd collaboration. Also a physiotherapist, Zhang is based at the Australian Catholic University as a PhD candidate and a sessional tutor. Claire agreed to join us as a presenter recently. She's a clinician in the private sector based in Dubbo in Western New South Wales. Claire trained in South Africa and moved to Australia after many years working there, and has been to a couple of the StrokeEd workshops and has changed from being a Bobath practitioner to a person who uses task-specific training. So she'll talk a bit about practice change. We will stop during the hour for some questions and to respond to some of the comments. You can put them in the Q&A at the bottom of your screen. You won't be able to use the chat and you won't be able to raise your hand as you may sometimes do in Zoom sessions. So use the Q&A at the bottom at any time, and we'll try and answer as many of those questions and comments as we can. There is no handout of the slides for the session, but Simone set up a link to a folder of information that you would have got in your emails. And that folder has resources about task-specific training or links to them, and the 2 systematic reviews and any correspondence about those 2 systematic reviews. If we run over at the hour, which is possible, we can do that, and you have to return to work, be assured that you can access the recording, which will be available within the next week. So I'll pass over to Simone now, who's got some slides to share.
Thank you for the introduction, Annie, and the invitation to talk at this de-implementation series of lectures. So tonight's topic is continuing the February topic of de-implementation, but with a particular focus on the de-implementation of Bobath therapy in stroke rehabilitation. And I'm very happy to be joined by Zhang and Claire in this presentation. The learning outcomes for this is that at the end of this lecture, you should be able to describe the UK guideline, UK and Irish guideline recommendations about the use of Bobath therapy in stroke rehab. That you should be able to then also describe some of the published studies that those recommendations come from, that Zhang and I will be talking through this evening, or this morning, wherever you are. I'm going to describe what task-specific training is, so we'd hope that at the end of this you feel confident to define what the key elements of task-specific training are, and that you can reflect on your clinical practice and your clinical setting, and how practice change can be achieved in your setting. The key messages for this presentation is that we have robust evidence for task-specific training in stroke rehab, and that this should be prioritised over any low-value care. There is some very specific clinical reasoning that's required to do effective task-specific training, and I'll be talking through what the features of that are. There are barriers and enablers to practice change, but it takes collaboration, and it takes support to make those changes. So I'll do a brief overview of the UK guideline recommendations. I'll talk about what evidence-based practice is. Zhang and I will then present the 2 systematic reviews that we've co-authored of Bobath therapy compared to other interventions in stroke rehab. And I'll define what effective task-specific training is. And then we'll hear from Claire about the clinician's experience of changing her practice. And then we'll have a Q&A session where we can discuss together the barriers and enablers to de-implementation and implementation. So the UK guideline recommendations recommend that for people with some upper limb movement after stroke, they should be offered repetitive task training in preference to other therapy approaches, including Bobath therapy. We have the same recommendation for people with impaired balance, that again, they should be offered repetitive task practice and balance training in preference to other therapy approaches. And the same recommendation for people with impaired mobility after stroke, that again, they should be offered repetitive task practice. And I would note there that the verb that is used in these recommendations is should be, because that is a strong recommendation in these guidelines. And what that is saying is that the evidence is robust enough to recommend that this is what should be happening. So what is evidence-based practice? Evidence-based practice is based on 3 pillars. And one of those is the use of the best research evidence. And so we'll be talking through some of that research evidence that underlies these guidelines. But we are all clinicians working, and we have clinical expertise behind us as well. So that is part of what we bring to our evidence-based practice. And of course, we have the person that we are working with, and we have their values and circumstances and their preferences. And an example in stroke is constraint-induced movement therapy. Constraint-induced movement therapy has very robust evidence for being able to improve arm outcomes after stroke. It takes some particular clinical expertise to implement it effectively, but you might have a stroke survivor who really does not like the idea of having their intact arm restrained, even though they meet the criteria for constraint-induced movement therapy. And I have a stroke survivor friend who's exactly like that. He says there is no way in the world that he would do constraint-induced movement therapy and have somebody put a restraint on his intact arm. So of course we are working with people, and we need to respect what their preferences are. And that is part of that evidence-based practice package. But what is absolutely critical is our awareness and acceptance of the best research evidence as one of those 3 pillars. As clinicians, we have a professional responsibility to be providing evidence-based practice and an ethical responsibility, because this is what achieves the best outcomes for the people that we are caring for. But the implementation of evidence-based practice is not necessarily easy, and it is worth reflecting on what it means for us at a personal level, what it means for us as people receiving medical care as well. Too, if we go to a health practitioner, we would expect them to be offering us the best evidence-based care, and we should be also providing the best evidence-based care. But this is not always an easy journey. It can involve a lot of change in the way we think and the way we practice. And a key problem here that we all face is that we are all human and we are all biased, and that is the human condition. We approach the world with our own beliefs, our own strategies for coping with this very, very complex world in which we live in. But we need to understand that we are all biased, and we will all be challenged by things that don't fit within our current worldview. But for us to be evidence-based practitioners, we can think about strategies that help us to accept new evidence and strategies that help us to continue to change our practice as new evidence emerges. This does take sustained effort and it takes much time, but it is absolutely our professional responsibility. We would expect no less of anybody that's caring for us, and this is absolutely what we need to be committed to providing in order to achieve the best outcomes for the people that we work with. I'm going to go on now to present the results of the systematic review that Zhang and I co-authored, and you can see the other authors there. And this is the first review I'm presenting, is the one that we did that looked at the effect of Bobath therapy on arm outcomes after stroke. It was published early last year in the Journal of Physiotherapy. The full references are at the end of the presentation, and as Annie said, there's a link in the email that came to you that takes you to a folder if you want to download a copy of the full papers that we're referring to tonight. The research questions, actually before I continue, I just would like to talk about why we chose to do these reviews. So obviously those of us from StrokeEd spend a lot of time teaching workshops, and I guess we had faced many questions about Bobath therapy and the effectiveness of Bobath therapy, and that has led us to see what existed. And we were quite surprised when we had a look that there was no comprehensive and recent review with meta-analysis of Bobath therapy compared to other therapies, even though there are quite a large number of trials that have investigated that. And so we chose to do this systematic review. You choose to do a systematic review, obviously, to investigate a question, and you follow very strict rules which are put down in order to eliminate bias within that process. And we followed the procedures laid out by the Cochrane collaboration for conducting systematic reviews. So in this, we looked at what is the effect of Bobath therapy on arm activity and arm strength outcomes. And we looked at that compared to a dose-matched comparison or to no intervention. We screened the major databases for any randomised controlled trials that met our eligibility criteria, which were that it was adults after stroke, that one group received therapy that was based on the Bobath concept, and that this targeted the affected arm, and that we could define the duration of the delivery of that therapy. And that it was then compared to another intervention that was delivered for the same duration or compared to no intervention. We collected outcome measures of arm activity and also of strength, and we included the Fugel-Meyer motor assessment as a measure of strength. We scored the quality of the included trials using the Pedro score, and the Pedro rating scale assesses the internal validity of a randomised controlled trial to tell you how robust that evidence is. In terms of the types of trials that we are looking at, the maximum score that they can achieve is 8 out of 10 because it's not feasible to achieve 2 of the criteria, which are blinding of participants and blinding of therapists, and that obviously would not be feasible in these types of studies. So in fact, the maximum Pedro score that these studies would be able to achieve is 8 out of 10. There were 13 trials that met our inclusion criteria. The Pedro scores ranged from 5 to 8, so they're reasonably high quality, those included trials. There were none that looked at a comparison of no intervention, and these are the comparisons that we looked at. So you can see the highest number of comparisons were task-specific training or arm movements, and I'll define those in more detail. And what I'll concentrate on tonight is the 2 largest groups, which were the comparisons with task-specific training and arm movements. So by task-specific training, we included in that group of studies any in which the intervention provided to that group involved reach, grasp, and manipulation of everyday objects. We did include the CIMT shaping within that task-specific training definition. The arm movements we defined as being active movements of the arm, but without the reach, grasp, and manipulation of everyday objects. And so these were studies in which people might have been doing active arm movements through their available range, but not using and interacting with everyday objects, as we defined in the task-specific training. Zhang and I will both be presenting our results on forest plots. So I'm going to explain how to interpret a forest plot, just to make sure that we're kind of all on the same sort of page with that. So you can see under a forest with a forest plot here, you have a line down the middle, which is the line of no difference between the control and the experimental group. You always look to the bottom of the forest plot to see what is represented on either side of the forest plot. And so here you can see we have the control group on the left and the experimental group on the right. This represents the results from a single trial. And you can see you have a box in the middle, and that represents the mean difference between the control group and the experimental group on that outcome. The horizontal line represents the 95% confidence interval. And what that means is that you can say that you are 95% confident that that mean difference between the groups lies between that lower and upper limits of that 95% confidence interval. But what that square represents is the best estimate of where the average difference is. So here now we're putting some individual studies into this forest plot. And you can see that these boxes have a different size. And what happens when you do a pooled analysis is that the different size of the box represents the different weightings that are given to different trials. So some of them will be given a higher weighting because their results are statistically kind of better results to use. The pooled analysis then is represented by this black diamond. So that's the pooling of the data from those 5 studies. The middle of that diamond represents the average effect size there, and the either end of that diamond is the extent of the 95% confidence interval. So you can see this pooled result tells us that the control intervention was better than the experimental intervention. And we can say that quite definitively because this diamond does not touch the line of no effect. Here we have a different example, and so here we have a pooled result that sits exactly on the 0 line, and it's also a very small diamond, which means that that you could say quite definitively that is quite a precise estimate, that result. And so you could definitively say that there is no difference between the control and experimental group for this intervention. Here we have a result that favours the experimental group, but the diamond does cross the 0 line, so it's not a definitive result. And you would summarise that by saying that the experimental intervention is better than or similar to the control intervention. And here we have a result in which the experimental intervention is definitively better than the control intervention. There is a convention for describing a standardised mean difference, and most of the results that we present tonight are represented as a standardised mean difference, which is a statistical value that is used when you have studies that have measured the same outcome but with different types of measurement tools. And this convention, called Cohen's effect sizes, is a very standardized convention for describing these that we will apply. So the first result that we are looking at is looking at upper limb activity outcomes, and we're looking at Bobath therapy compared to task-specific training. So there are 5 trials within this pooled analysis, and you can see that this is a definitive result in favour of task-specific training, which is on the left-hand side of the plot. The effect size is an effect size of 1 in favour of task-specific training, and that is a large effect size, with the estimate ranging from a moderate to a very large effect size in favour of task-specific training for upper limb activity outcomes. The mean Pedro score is 7, meaning that those trials are quite high quality trials, given that the maximum possible score is 8 out of 10. This is Bobath therapy compared to arm movements, and just reminding that arm movements was active practice of arm movements, but without the reaching, grasp and manipulation of objects. You can see that this is not a definitive result, but we can say that arm movements is better than or similar to Bobath therapy for upper limb activity outcomes with a small effect size. And again, reasonable quality of the trials included in this analysis. Still looking at the upper limb activity outcomes, one trial reported activity outcomes that looked at a comparison with robotics, and that favoured the robotic therapy. One trial looked at mental practice, and that did not show a result in favour of either intervention. So in conclusion, task-specific training is more effective than Bobath therapy in improving arm activity and arm strength after stroke. I'll just point out that I didn't report all the individual outcomes, but you can certainly read that in the article. Robotics and arm movements are similar to or better than Bobath therapy at improving arm activity and arm strength. And mental practice, it's an unclear result. The clinical implications of this information is that we should be providing task-specific practice in quantity as well too, because we know that as well. We can also use arm movements and robotics, because while the results are not as definitive, I think what we do need to recognise is that the interventions of arm movement, remember that's the active arm movements, but without the reach and grasp of objects. Arm movement practice and practice with robotics can be done intensively, and it can be set up and done without a therapist being present. And we know that intensity is extremely important in stroke rehabilitation. So I think that really is also an indication to prioritise these interventions over Bobath therapy. I'm going to hand over to Zen.
Okay. Hi, everyone. Thank you, Simone, for the wonderful presentation on the upper limb systematic review. and thank you, Annie. So before when I was involved in the upper limb, I was involved in the lower limb systematic review for looking at Bobath in comparison to other interventions for lower limb activities after stroke. So the primary aim of this systematic review was to look at the effect of Bobath therapy on lower limb activity. And the secondary aim was to look at its effect on lower limb strength and lower limb coordination, and comparing Bobath to other interventions or no interventions at all after stroke. Very similar to upper limb methodology, we screened databases up until early 2019. We looked at participants after stroke, and we included interventions which had one group that received Bobath therapy based on Bobath concept, and the other group which received therapy based on, received a comparison intervention or no intervention. The primary outcome measure, as I mentioned before, for this systematic review was on lower limb activity. And these activities include sitting balance, sit to stand, standing balance, walking, stairs, etc. And the strength outcome measures were taken from the, as a secondary, was taken out as a secondary outcome measure. So for tonight's presentation, I'm going to focus on the primary outcome measure, which is the lower limb activity for today. So we screened 22 trials, or we found 22 trials which fit our criteria. The Pedro score of 2 to 8, which is a bit of quite a range in terms of the quality of the studies included. We identified no trials which compared Bobath to no intervention. And as you can see, about half of the studies that we've identified were comparing Bobath to task-specific training, followed by combined intervention and strength training. So for tonight, I'm going to really focus a lot on task-specific training because that's got a lot more evidence involved, and you can read the other studies in the paper. Okay, so just a note of caution here. The forest plot for the lower limb systematic review is flipped around compared to the upper limb. So if the diamond here falls over on the left-hand side, it's going to favour the Bobath intervention, and if it's on the right, it's going to favour the comparison intervention. And I'm going to mainly present on task-specific training because that's where we got the most robust evidence. This is the outcome for the combined lower limb activity, where we've found 9 studies that we found a moderate effect size in favour of task-specific training, and we can be fairly confident of this result. And as you can see, the Pedro score is relatively high, so that the outcomes are quite reliable. The results are quite reliable. And I'm going to briefly touch on what the results were for Bobath therapy compared to strength training for lower limb activity. As you can see, we had 2 trials for looking at Bobath compared to strength training for lower limb activity, and the results were in favour of strength training. However, it was a bit more of an imprecise estimate. There was one study for Bobath that looked at compared Bobath with proprioceptive neuromuscular facilitation, and this is the one trial that found it was favouring Bobath with a fairly large effect size. When it comes to combined intervention, there was no strong evidence to favour either interventions for lower limb activity. So lower limb activity was then further analysed to look at other specific tasks such as walking, sitting balance, sit to stand. So I'm going to present walking first. 7 studies identified for this meta-analysis, and we can see that there was a moderate effect size in favour of task-specific practice, and we're very confident with this result for walking outcome. And the Pedro score over 7 is once again a very high quality studies that we've included. And when we looked at walking as an outcome and Bobath therapy compared to strength training and combined intervention, we didn't find that it was in favour of either interventions for walking as an outcome. So when we looked at Bobath compared to task-specific training for standing balance, this is activity on standing balance. As you can see, the diamond here crosses over the line of 0, which means that there is a small effect in favour of task-specific training, but the measurement is not as precise. And a very similar finding for sitting balance. Once again, here we have a small effect from the 3 studies, and the measurement and the estimate is not as precise. When we're looking at sit to stand, there were 2 studies that were identified. There was no clear evidence in favour of either intervention when Bobath is compared to task-specific training for sit to stand, and very similar results for stair climbing for the 2 studies that we identified. There was no results that was in favour either intervention. So in conclusion, this systematic review showed that task-specific training is more effective than Bobath therapy for combined lower limb activity outcomes, and specifically it is more effective than Bobath for walking outcomes. When we look at other therapies can be similar or better than Bobath therapy for lower limb outcomes. So it really challenges a clinician's thoughts on prioritising Bobath therapy in stroke rehabilitation, especially in this time-tight health environment. That we should prioritise task-specific training over Bobath therapy for lower limb activity, and that therapy environment really should be set up to allow more active and intensive practice, which are meaningful for the stroke survivor who's in front of you. Okay. Yes.
Share shuffle.
Yes.
I wonder if we should pause there, Annie, and see if there are any questions before I go on to talk about task-specific training.
Sure, Simone. There's one question that's just come up now about the graphs showing a difference on what is in the results written in the paper, which consistently says no difference. Now, it might be that specific questions that look at some of the text in the paper are difficult for you to answer live at the moment.
You will find, if you look at the text that's describing the forest plots that we're talking about, where there is a difference, it will be described as such in the text.
Okay, so I think if there are any details about specific lines of text and statements,
might be a bit hard.
It's going to be hard to do that live, so just be aware of that. Somebody's saying, can you define Bobath, please? It is in the paper as a definition, I think, isn't it?
Yes, it is in the paper as a definition.
So maybe one of you
can... when we really searched for trials in which they explicitly stated that they were using Bobath therapy, or they particularly referenced a Bobath text when they talked about the type of intervention used, or they used specific sort of Bobath and particularly some of the terminology around facilitation, which is obviously a key cornerstone of Bobath therapy.
That's why you're waiting to find the definition. Somebody's asked the question, what are examples that fall under Bobath therapy? And I think whoever that question has come from, you'll need to be more specific. I don't quite understand what the question is asking for, what kind of examples. If you want to know the specific studies, they'll be in the systematic review, and you can follow them up.
This is kind of word for word in the out of the systematic review, that the trials had to meet one of the following criteria. The authors stated that it was based on Bobath or NDT. They referenced a Bobath text or publication when describing the intervention. The intervention description suggested that it was based on Bobath, i.e. aimed to normalise movement, normalise tone, facilitate movement, or inhibit reflex activity. Didn't have to do all of those things, but the terminology suggested that it was based on those concepts.
Thanks, Simone. And somebody's asked a very good question, which is related to some of the people that we would see clinically. It's how would you address the what they're referring to as increased muscle tone or overactivity that's often caused by increased effort. It seems that you need good handling skills to facilitate the reduction of muscle tone before and after the session, like a warm up and worn down. And this important element was not included in the trials as far as I can see.
Yes, I think that is a great question. I think that does come down a lot to kind of movement analysis and thinking about the task and the way that the task has been set up. But if somebody, for example, who has strength and coordination problems in their arm after stroke is trying to do something that's quite effortful, maybe they've been asked, maybe they're trying to practice with cutlery, and quite a typical thing that happens is they might be being asked to cut through putty, which is a very difficult thing. And that will mean that they end up using lots of excessive muscle activity, which sometimes might be interpreted as spasticity or increased tone, but really might be the task that's driving excessive muscle activity, or because they can't switch on, not got enough strength and coordination in some muscles, they turn some other muscles on, or biomechanically, the only way they can get their arm here is to maybe come into, for example, into abduction and internal rotation, because they haven't got the strength in their shoulder forward flexors to come into that forward flexion position. So I think it does come down to analysing what's happening and what's causing that kind of excessive muscle activity, because maybe it is to do with strength and coordination problems. Maybe it's because the task that they're being asked to do is actually too difficult, and the task that they're being asked to do, it needs to be modified and made easier. So if they're being asked to cut through really tough putty, you maybe make it, get something that's much softer to cut through, for example. We'll have a look at some examples of task-specific training and how things can be modified to make things easier. But I think that is our skill as therapists, is in the modification of tasks to make them more achievable with the levels of function that people have. I don't know if we could talk about that question for a long time, so I don't know whether we should move on.
I think I'd like to add, Simone, this is a question that comes up in our workshops quite often, and I would say the answer is no. I wouldn't use it as a warm-up, because what you're doing is taking away that very valuable time that you have one-to-one with somebody, and using it on a treatment that has not been shown to be as effective as task-specific training. So if somebody's very weak, for example, which is a couple of the other questions coming up, somebody has minimal muscle activity, they can't lift their arm off their lap, what you're trying to do is find a way for that person to begin to move their anterior deltoid, begin to protract their arm, and finding a setup, which you'll see Simone showing you shortly, where the person can do that. And it can take you quite a while to find a position where the person can practice in a semi-supervised way with a family member on the ward or at home. So taking 5 minutes away of your 45 minutes is not a good use of your time when you know that you're going to need as much time as possible. So that sort of answers one of the other questions that's come from a couple of the other audience members about what to do when people have very little muscle activity.
Yes. I guess the really key thing there is finding ways for people to actively practice, because that's usually what's needed to get neuroplasticity and help increase their strength. Yeah.
And tomorrow night we have a lecture on implementing mental practice as one of the treatments you definitely could use, along with mirror therapy and electrical stim, to help elicit movement activity in the arm and as well for some cases in the leg.
And maybe I should add, Annie, that we have an entire recorded lecture in our recorded lecture library on strength after stroke, and looking at what's the evidence for various interventions that can be used to strengthen muscles, from muscles that are paralysed and very weak through to muscles that are kind of grade 3 or grade 4 in strength.
Yeah, there's a couple of other questions that I might ask you to respond to, and that's about the definition in the papers, the randomised trials of Bobath. One person saying that what we've talked about so far is perhaps an outdated description of Bobath, and somebody's asking, how was Bobath measured? I presume you mean how were the outcomes measured, or how was Bobath described and defined? And it was quite difficult in the papers. There wasn't a lot of description provided, but people did clearly say Bobath or something that seemed to be Bobath.
Yeah, so I guess in response to the question about recency, in fact, just I think it's only in the upper limb review, just about all the trials have been published since 2000. And quite a few of them since 2010. So they're actually not that old in terms of the recency of those trials. Some of the ones in the lower limb, there are some that are a bit older, but there actually are quite a few quite recent ones as well. So they're actually, a large number of them actually are relatively recent.
There's a couple of other questions you'll see on the screen. Do you want to take them now or wait?
Do you think, shall we move on, Annie, and then come back? Okay. Maybe. Okay. So I'm going to talk now about what is task-specific training, because I think there are some very critical features to set up effective task-specific training. I'm going to start with a couple of quotations. One firstly from Isabel Hubbard, who talks about the fact that task-specific training uses the performance of functional tasks, functional like as in everyday tasks. So it's goal-directed practice and it's done repetitively. The Cochrane Systematic Review of Repetitive Task Training defines it as being an active motor sequence that's done repetitively. So I think the important thing there is that it's done actively, that it has a clear functional goal, so it's related to some kind of functional task. It does also include this concept of pre-task movements. So you might have some kind of movement, but if it's complex and multi-joint, that also fits under that umbrella of repetitive task training. The Australian Stroke Guidelines talk about their strong recommendation here for improving walking after stroke is that people should undertake tailored and repetitive practice of walking. So I think that word tailored is important, or components of walking. And so here we have a distinct, I guess, description of the concept of part practice, that you will take out a component that somebody is having particular difficulty with. And so that practice is tailored to specific problems that they're having, and that it can include practice of that component. And it's done as much as possible. So the critical features there are that it's goal-directed practice, it's very everyday activities, because obviously those are the things that people have in their goals that they want to be able to do. That it's done actively, it's not active assisted or passive movement, that it is actively done by the stroke survivor. It's repetitive, it is targeted, that word tailored or targeted towards the specific movement problems that person has. So it involves some analysis of their specific problems and setting up that practice to address those specific problems, and that it can include that part practice or component practice to target specific problems. Gavin Williams wrote a really good kind of discussion protocol kind of paper, I guess, looking at what is critical in exercises that are targeting improvements in strength and power to improve people's walking. And he describes the need to have a very clear understanding of the biomechanics of walking in order to be able to prescribe the right kind of exercises. So an understanding of what muscles are critical to achieve the movement, what those muscles are, the type of contractions, the type of ranges that they're moving through, the speed that they're moving at, for example. So critical features there, that the practice should be very specific to improving the task, improving the components that need to be improved as well. So what muscle group does it need to be? What joint angles are they moving through? Is it a concentric or an eccentric muscle contraction? What is the timing and speed of that muscle activation? I'm going to show you some videos that are examples of task-specific practice and talk about some of those features. So this man is practicing plantar flexion to achieve a better push-off at the end of stance phase. So you can see his affected leg is his left leg. He has to step his intact leg quite far forward and up onto a block in order to encourage him to get, and what we're trying to achieve here, to reproduce those biomechanical requirements of that component, is that he gets a rapid concentric plantar flexion at the end of stance while he's still actually in some single stance before his right foot hits the block. Here we have a man who is practicing to improve his single leg stance on his right leg, on his affected leg, and he's bringing his left leg across into a very narrow base of support, and that's being done in order to improve his ability to adapt over his right leg in stance phase of walking. Oh, sorry, thought she wasn't going to start then. Here we have a lady practicing a reaching task. You can see that it's been set up with a very everyday object, but it's been also set up specifically to give her some feedback about her coordination of that movement. And so she has to lift the small can onto the large can and try not to let the ball drop off. She's obviously having some trouble controlling the internal external rotation at her shoulder and getting smooth movement into forward flexion. I'd point out as well that she's practicing in an arm group, and so she's practicing without a therapist with her. You can see at the end she reaches for the clicker. She's keeping track of her repetitions. So there's certain elements of that practice that are driving that active and repetitive practice, keeping track of her repetitions in order for her to know how many she's doing and increase her numbers over time and make her practice intensive. So there was a question there about setting up practice when people are very weak. This man has a much weaker arm, his affected right arm, and so he's practicing sort of reaching forward, but he's actually sliding the cup along his leg because he's too weak really to effectively lift his arm up against gravity. So it's kind of modifying the task in order for him to be able to actively practice that task, but when he does have very significant weakness. And here we see Carl practicing with a stroke survivor who you can see has probably some quite significant attentional impairments. And he's set up a task for her to practice that is encouraging her to load her right leg, which is her affected leg, and that sort of reaching beyond arm's length to the right is really encouraging her to activate her right quadriceps particularly. And you can see Carl is palpating to feel that, but you can see he's not actively assisting the movement. He's just checking that she is activating her right quadriceps as she reaches across. Here, this kind of reproduces that concept of doing a multitask kind of movement. So we see a man here who's on a sliding tilt table. So this is a tilt table that slides away from the foot plate. So he starts in flexion and he pushes into knee extension. This will be mostly achieved by his knee extensors, but there can be some contribution also from his hip extensors and plantar flexors. But you can see this is a man that has very significant weakness of his affected left leg. But he's practicing this kind of component of extending his left leg to help improve his sit to stand and his standing, obviously his ability to weight bear on his left leg. You could see that the common features of these exercises are that apart from Lindy, people are practicing without a therapist. This man is practicing with actually his daughter is supervising his practice, not a therapist. So you can see some of the very critical elements there are that it's active practice. The environment is set up to drive the practice. So the environment is set up here to give Avis feedback about the smoothness of her movement. The environment is set up here to really encourage this man to get that push off by having his right leg go quite far forward. The environment is set up here to really try and force that adduction over his right leg in single stance during this exercise. And the device here is used. The sliding tilt table enables this man who's very weak to practice and do many, many, many hundreds of repetitions that he needs in order to strengthen his left leg enough for him to be able to weight bear effectively on his left leg. We should mention also the concept of context specificity. So we've looked here at some specific tasks, but when we think about reaching and manipulation, there's many contexts to that, the types of objects we use of different shapes and sizes and weights. And so that task-specific practice needs to consider the context of that task. So different textures, whatever is required in order for that person to be able to then generalize that task. And if you're training walking with somebody as they progress, you need to bring in the kind of contexts that are needed for somebody to be able to walk, the kind of challenges of having to negotiate around other people or crossroads, or so we have that concept also of context specificity of that task. Task-specific training applies what we know about motor skill acquisition, what it takes to achieve neuroplasticity. And so we have the concepts here of needing intensity. People need to be set up to be able to practice intensively because it takes hundreds and thousands of repetitions of practice to achieve neuroplasticity. We know that motor learning is much more effective when people have an external focus of attention. So what they are thinking about as they practice is what is the outcome of the movement, and that is driven by the environment set up, lifting the can onto the top of this, stepping this foot to here. There's the use of objective feedback and goal setting so that people know that their performance is changing session by session and day by day. And you can see in all of those tasks that those people were practicing, there would be ways of providing them with objective feedback, maybe about how long it takes them to do the task or their accuracy doing the task. So that can be used to help to motivate people to achieve, that can be used to help to motivate people to achieve those larger amounts of practice. Shall we break for questions, or?
Yes, I think that would be good. We've got 4 or 5 questions there.
Yeah.
The first one up the top there is looking for a common question that we get is defining Bobath, and I think that's a difficult question to answer because lots of people have different definitions. There's been a few publications about this, but the bottom line is when you do a randomised trial, you have to define and specify what the therapists and the research assistants in your studies are going to do, and we have to rely on that in the randomised trials. And if people can't do that well, what you get is what you get in the outcomes. And with task-specific training, we also have similar problems in defining what exactly people are doing in trials, and that's why we have attachments often to the papers and protocols that clearly define what's done, and you have pictures of the exercises that are done. Anything else you'd like to add, Zheng or Simone?
No, I think it is a problem, and obviously we've taken people's descriptions at face value. If they said they were doing Bobath, we put them, we included them. But I think if you want a definition of what is defined as contemporary Bobath, you probably should have a look at the work that comes from some of the leading Bobath institutions.
And one of the questions there is about the Bobath, including movement analysis and repetitions and practice of tasks. I think lots of people will argue that as well. But if you look at the examples that Simone just provided you with in the videos, there's not much hands-on training going on. There's not much facilitation. And I think that is one of the key differences, is setting people up for independent or semi-supervised practice right from the very first session, and minimizing the amount of manual guidance. The next question is about studies in different countries that use Bobath. Is there any difference in rehab outcomes? And I don't think any of that's ever been examined.
No, I don't think we have that kind of level of detail.
Yeah. Then can you tell us a bit about the difference between task-specific practice versus arm movement? Task movement.
I think it's a kind of a good question, because it's a bit of a fine line, I think. We kind of broke up the studies in the upper limb review, because some of them literally, in some of the studies, people were kind of just hanging on to something and moving it from one side to another, and that was the only movement that they were doing. And so they might have even had their hand sort of attached to this bar that they could move in space or something like that. So it wasn't assisted movement, they had to actively move, but it wasn't really task-specific practice. It didn't involve any interaction with any sort of everyday objects or anything like that. So I think if you look at a more pure definition of task-specific practice, it is in the context of the upper limb. Really, it's reaching and grasping and manipulating with objects the way that we use our arms. In the lower limb, it's sitting, sit to stand, standing, walking. But then when we have people who are very, very weak after stroke, we can also be doing what you might call some kind of components or pre-task. And in the French, Cochrane systematic review, that concept of complex multi-joint movements that might not really represent a task. And I think maybe the sliding tilt table leg extension is a good example of that. But I think it's probably sometimes a bit difficult to draw, like what's just a plain strengthening exercise and what's task-specific practice. I think if we go for that definition of it being more complex and multi-joint, I think we could call it that it's a component of movement. But if you had somebody sort of, literally just doing flexion extension of the elbow, maybe it would be more accurate just to call that a strengthening exercise.
Maybe one more question, and then we'll go on to Claire's presentation, just in the interest of time. That question there about pre-task movement being part of, is it task-specific practice or motor skill acquisition? In your definitions earlier.
Well, it's all about motor skill acquisition, isn't it? I think, even when we go back and think about just doing some isolated strengthening for very, very weak muscles, that's still for the purpose of somebody being able to do motor skills. But I guess if we're thinking purely about motor skill acquisition, purely motor skill acquisition would be about practicing the task that you're trying to get better at doing. But in the context of stroke, we have people who can't always do that. So I think we do need to also recognize that we will modify tasks, we will break tasks into their components for the bigger kind of purpose of motor skill acquisition.
I'll leave you, Simone and Zeng, to maybe have a look at the remaining questions. And if you want to type an answer to any of them, the audience will see that while Claire's presenting. Over to you, Claire.
Thank you. Hi, everyone. I'm Claire, and thanks for being here tonight and sticking with us with the time. I'm here to give you a clinician's perspective on the de-implementation of Bobath. I'm not Bobath accredited, and I'll be speaking from my own experiences today. So a little backstory, I'm South African, and I did my Bachelor of Physiotherapy degree in Cape Town about 20 years ago. Our neurological program was largely based on the Bobath concept, and we practiced a lot of hands-on facilitation. Thereafter, I worked in the UK for about 8 years, and all the neurological settings I worked in were practicing Bobath principles. Fast forward to when I decided to move to Australia, and to gain registration, I had to undergo a rigorous written and practical exam process. This included a neuro-prac exam with real patients in hospital settings. It was at this time that I learned about task-specific training and heard the names Carr and Shepherd. I was largely focused on passing the exam, and everything I learned was very much rote learning. I don't remember ever comparing my current practice with what I was learning, and basically I just added it to what I already was doing for a successful exam process. For the past 10 years, I've worked in New South Wales, in Australia, in private and public health. I have practiced in acute and rehab settings, including some time as a clinical educator and physiotherapy manager. In 2021, Western New South Wales Health hosted the StrokeEd course, and it was a fantastic opportunity for rural physio to update their stroke evidence-based practice. I remember sitting in the first couple of sessions and having my mind absolutely blown away with what Carl and Simone were teaching. And then in shock, looking around the room and realizing that I was the only one with my jaw on the ground. I had a range of emotions, largely shame and guilt. How could I have been so wrong? What inaccuracies had I been teaching my students for so many years? And what effect did it have on my clients? At that time, I was also labeled the neurophysio in the team, and my colleagues often came to me for advice. I honestly thought I was up to date. My clients always seemed to improve. To be honest, I think I was stuck in a cycle of doing what worked and doing that all the time. I was basing all my decisions on past practice and results. I only had 2 of the 3 pillars of evidence-based practice, as Simone illustrated in her earlier slide today. I was missing best research or evidence. But in the end, I found peace in realizing it wasn't bad practice. What I had done, I hadn't harmed anyone. It just wasn't best practice. I wasn't comfortable continuing knowing that what I was doing wasn't best practice, and knowing I wanted to do what was best for my clients. If I was in their shoes, I would want my physio to do their best too. So how did I change? In some ways, it was pretty easy for me. I love change, I love innovation, and I love trying new things. I soaked up all the learning and practical experience on the StrokeEd course. This time, the difference being no rote learning, but rather practical, real-life application of task-specific training for stroke survivors. I went straight back to work the next week, and I changed my practice. I had to make a real effort to become hands-off, to focus on the client's goal-related task, and to enable more semi-supervised and independent practice to achieve the intensity required for maximum results. I tried my best to avoid internal feedback and to stop talking so much. I was starting to allow my clients to take ownership of their recovery and empower them to become stroke survivors. I appreciate not all of these changes are directly related to my foundational training in the Bobath concept, but also inferior practice habits built over the past 20 years. However, the more I implemented task-specific training and de-implemented Bobath, the results spoke for themselves. And I was pretty convinced pretty quickly. My clients loved it. It made sense to them, and it made sense to me. I was lucky I didn't get any resistance from my colleagues because none of them are Bobath trained, and all of them have studied in New South Wales. They didn't question my change in practice, and it was in line with what they already knew. So my advice to those of you considering the de-implementation of Bobath: be kind to yourself. Try not to focus on what you did in the past and how that may not have been best practice. Change can be hard on us. My identity is closely linked to my career as a physiotherapist, and I get a lot of self-worth from my clinical practice and professional experiences. When you are made to question the practice, it is very easy to give yourself a pretty hard time and question everything you have ever done in your professional life. When you value your career as your identity, change can be particularly hard on your mental health. So be kind to yourself. Also acknowledge that change can be harder for others, especially if the clinicians around you are not willing to change. You being here today tells me that you are in the contemplation stage or maybe even ready to take action. Your colleagues may not be in the same stage of change as you, and they may need a bit more time to reach that action stage, if at all. So be kind to them too. My final bit of advice would be to commit yourself to evidence-based practice in every session you do with every client, no matter how well you know them or for how long. Ask the question: is this evidence-based practice? Do I have the 3 pillars? Clinical expertise, patient values and circumstances, and the best research or evidence. If you don't, then find out. Go on a course, ask your supervisor, get a mentor, do a literature search, watch an online lecture, like you are today. There are so many ways for us as physios to stay up to date that there really is no excuse to not follow evidence-based practice in our clinical sessions. Thank you.
Thank you very much, Claire. So I guess what you're talking about is addressing some of the barriers to practice change. Once you know what you have to do, you need education and skill development. They're kind of fairly common challenges when people are trying to change what they do. And you didn't have the difficulty of working with people who were very strongly wanting you to continue to use a treatment at the workplace where you were based. One of the questions I wanted to ask you about, there's a couple of people asking, when would you use sensory or proprioceptive input? When will you do his hands-on therapy? And my comment when I get asked that question at workshops is, what you're really trying to say is you want to use an eclectic approach, a bit of this and a bit of that, and that's not okay. What you want to be doing is using the evidence-based treatments that have been shown in trials to produce better outcomes for walking or arm recovery. And if you water it down by doing a bit of this and a bit of that, you're not doing the best that you can. So using lots of facilitation and hands-on therapy is kind of feeding into that idea of using an eclectic approach. But there are times when you do have to put your hands on and help somebody. So maybe, can you think of any examples where you would do that, whether it's to do with training arm function or helping somebody with learning to sit?
Yeah, I really think like hands-on when it comes to safety is obviously one of the areas that I can think of there. So obviously you would never step away from a patient if you feel like safety is an issue. So especially when you're practicing transfers, I would often be quite close to the patient, but definitely not in a facilitation type of role. So that's where I really changed, where it was more just to be standby assist or assist if they need it, to be able to successfully make transfers as an assessment purpose, or when it came to treatment, like Simone said, you would probably make that transfer easier for them so they can do it in a semi-supervised way. And then with the time you have with the client, you might make it more challenging and be closer to the client, but definitely not. I've stopped using the facilitation points. I've definitely stopped, sort of giving the person sensory feedback with tapping in certain areas. I'm not saying there's no place for hands-on. I'm just saying I'm not using it in a facilitatory type of role, but certainly it doesn't overtake from safety. Safety is obviously paramount in these situations. So yeah, that would be my input there. I don't know if Simone or Zheng have anything more to say about that.
Yeah, I think there are certainly times, if you've got somebody in your, when you think of that, the lady Lindy who was quite the one that Carl was doing sitting balance with, who's having trouble weight bearing onto her right leg while she does some reaching and sitting. When you first start to do that, to apply some downward pressure down through her knee might help her to get the idea of sort of pushing down onto her leg. But you would do that, and then you would take your hand away as soon as she gets the idea. So sometimes there is some value, I think, in indicating a movement or providing some manual guidance. But I guess the important thing is that you then hands off as soon as possible.
I think the other examples that you showed on the videos of somebody with upper limb problems, that man who was practicing shoulder forward flexion and sliding a cup along his leg, instead of facilitating the person, you're finding a position and a setup that the person can do either on their own or with a family assisting on the ward or at home.
Yeah.
Okay, I think we're 10 minutes over time. We probably should start to wrap up, unless there's any questions, Simone, that you would like to respond to.
There was one that I wanted to respond to, but I can't see it now. It was one about providing specific sort of sensory input.
I think that was looking at proprioceptive input, so I've answered that one.
Yeah. There's another question there about sensory retraining, and I think when you think about specific sensory information, there is some evidence, and there's a weak recommendation in the Australian stroke guidelines for sensory retraining in people that have sensory deficits in their upper limb. But that is about the very active exploration of objects and using that information to I guess really sort of increase neural plasticity around the sensory input that somebody's getting. So that is, very sort of specific sort of retraining for somebody whose loss of sensation is causing them activity limitations in their hand, for example. And I think we can think sometimes about providing added sensory feedback in the context of biofeedback. If you're working with somebody, for example, who has poor proprioception in their affected leg and maybe poor tactile sensation and is not really aware of how much weight they're putting onto their affected leg, it probably is really very useful maybe to set them up with some kind of scales underneath their affected leg, matching height block underneath their intact leg, and them getting some feedback from the readout of the scales to see how much weight is on their leg if they can't feel how much weight is on their leg. But so that is kind of addressing the fact that people have these complex sort of impairments that include loss of tactile sensation and loss of proprioception, and thinking about how you might set up training in a way that gives them some added useful information while they're training. But that's in the context of sort of really of biofeedback, not of therapists doing things to them.
And can I just add on to the taking hands off as well? I think when you are able to prescribe or give help a patient with working out an exercise that is within their capability and they're able to do it without having someone having to hold on to them all the time, I think that really gives the message that you send to the patient is that you're able to do this particular task. And I think that's quite a powerful message for the patient to learn that they're able to change, they're able to improve, and they can get better without having someone to be holding on to them all the time, and that your therapist then becomes a coach as opposed to someone who's hands-on with you all the time.
Claire, do you want to comment on that? Because somebody's asked a question at the end there about what sort of changes you see when you give people.
Yeah, I saw that one. That's a great question. I think it feeds nicely into what Sing was saying. I think there's a lot of power. I mean, how often has a client said to us, we've gone, well done, you did whatever, and they've gone, oh, but you were holding me, or I needed two of you to walk So how powerful is it when they can take ownership of that and realize they did that with very little assistance or no assistance at all. Also so powerful when you can have the carer involved in that moment. So, you're not even, assisting or supervising the client. It's someone that's really invested in their recovery, and that's what happens with semi-supervised. Addressing what that last question was around, the changes in the patient's motivation and how they changed to when I changed my approach. I mean, it's very powerful when a client is working on a task that's something that they chose. And I think so often as physios, we in our head already have what we think the patient's goals are. But when we actually take the time to coach someone and nut out what tasks are important to them, and when they see that whatever task we're asking them to do in therapy is directly related to that task, it's very powerful and provides a lot of motivation towards therapy, which is really important in those early days of stroke, when we often see people that are quite fatigued and have often some apathy and decreased motivation. I think also, the benefit here that I found when I went back into my direct job at the time was time management, that we only have a very small amount of time to spend with our acute strokes, often once a day, no more than 20 to 30 minutes. So to get the intensity required, we have to change. We couldn't be hands-on because we physically didn't have that amount of hands. So, I saw that as a huge improvement in delivering care to my clients. And I think, the client also saw themselves doing more. How often in rehab do you hear clients saying, why can't I come to the gym all day? Oh, well, we don't have the ratios to support you being in the gym. You have to have a physio with you. Well, no, if we do follow the staff-specific training where they can do semi-supervised staff, they actually can. It does enable them to have more treatment, which then shows more improvement, which has better results on both sides, patient and service related. So, in terms of replying to that question around, how the patient responded, I think it benefited the patient just as much as it did us as a service.
Mm.
Now, Simone, if you have some references, you might want to put them on the screen and leave them up there.
Thank you.
And that's a good point for me to remember that Zhang last year did a very good presentation on using classes to increase the amount of practice and intensity and how to set them up safely. She also talked about doing some of the sessions by telehealth as well as face-to-face for balance training, upper limb training, lower limb training. So I'd encourage you to listen to that recorded lecture from last year or the year before, I forget, about doing classes in rehabilitation. So I'll let you finish off, Simone.
Yeah, so I'll just say this QR code here just goes to a Google folder that contains the reviews, the associated correspondence, and there is a document in there that has got resources for task. Really, it's just a set of web links to various resources for task-specific training. There's the key messages. I think we might have gone through those. And this is the references. There's one more question that I think is probably important that I would like to answer, Annie, is that somebody concerned that if you're concentrating on repetitive task practice, you might be ignoring the development of contracture or ignoring people's pushes syndrome, for example. And I'd say, doing repetitive task training is not about ignoring other important impairments or other secondary impairments like contracture. It's still, those things still have to be dealt with. Probably the best way to address pushes syndrome is to do a lot of active task practice, but with a cue for verticality to help somebody to overcome that pushes syndrome. So I guess I think it's important to state that because you're doing active task practice doesn't mean that you're ignoring some of the other impairments that people have after stroke. You need to adapt your practice to address those impairments.
Okay, thank you to the three of you, Simone, Zhang and Claire, and thanks to all the audience who've hung in there for the last little bit. The recording will be available in about 3 or 4 days. And if you're interested in mental practice, log in tomorrow night again for mental practice. Thank you very much.
Thank you. And thank you, Claire. Thank you.
Thank you. Thanks, guys. Thank you so much.